Those select few who are still fortunate enough to have a plan participating in their area would see their benefits slashed and out-of-pocket costs increase. According to CBO projection, these cuts would reduce Medicare Advantage enrollment by $7 million. MedPAC's stated belief that financial neutrality, in quotes, will foster efficiency and innovation is also off base. The suggestion that plans in Miami, Florida are somehow 4 times as efficient as plans in Midland, Michigan defies logic. To presume this to be true is irresponsible and harmful to the seniors I represent. It's unfair to single out Medicare Advantage and the 9 million beneficiaries who depend on the program for their health care to address all the financial problems facing Medicare. I want to be clear that I'm not suggesting that we shouldn't look at savings opportunities in the Medicare Advantage arena, including adjusting the benchmarks to recognize true market forces. At the same time, no provider should be above reform or scrutiny. I appreciate MedPAC's thoughtful recommendations on the many Medicare providers that we will hear about today, not only how they should be reimbursed, but how to improve quality in the various sectors. I also appreciate MedPAC's continued call to provide dialysis providers with an update, something I've long advocated for, and I thank the Chairman and yield back the balance of my time.
If other members have opening statements, they'll appear in the record in their entirety without objection. And Glenn, while normally we would ask witness presenting to time limit their remarks, why don't you proceed to summarize your testimony however you desire, and at the conclusion of that, we'll try and drill a little deeper with our inquiries. Why don't you proceed?
Thank you, Chairman Stark and Ranking Member Camp, other members of the subcommittee. Appreciate the opportunity to talk about our March 2008 report. I will keep my comments very brief so we can spend time on the issues that you want to discuss. Our March 2008 report includes 21 recommendations, 7 related to payment updates under traditional Medicare, 7 related to Medicare Advantage, specifically the SNP portion of MA, 3 related to the Medicare savings programs, 2 related to quality for skilled nursing facilities, 1 on indirect medical education, and 1 on Part D. For those 21 total recommendations, there were a potential 357 total votes. Of those, 332 were yes votes and 5 no votes and 4 abstentions. So as in the past, we managed to achieve a high level of consensus within the Commission about our recommendations. The one summary statement I would like to make, Mr. Chairman, is that the Commission does share the growing concern about Medicare costs. We're not only concerned about the potential burden on taxpayers and on the next generation, we're also concerned that how Medicare pays contributes to cost growth in the whole healthcare sector. That is having a number of detrimental effects, including adverse effects on coverage. We all wish, that there were a silver bullet for all of this, but clearly there is none. For our part, MedPAC recommends a combination of restraint on fee-for-service updates in traditional Medicare, reduction in Medicare Advantage payments, plus changes in how we pay providers, more accurate pricing, rewards for care coordination, bundling of certain types of services, et cetera. Because changes in payment systems are complex to design and sometimes even more complex to implement, not to mention uncertain in their effect, we believe it's important to start now, work aggressively to improve our payment systems and fund CMS appropriately for that task. Meanwhile, in the short run, our focus is on restraint on the Medicare updates for fee-for-service providers and Medicare Advantage. It's our belief that slowing cost growth and improving efficiency requires constant pressure on rates, both in traditional Medicare and Medicare Advantage. In a competitive market, the restraint on price, that pressure on price, is more or less automatic and relentless. The market provides it. In Medicare's administered price systems, both on the Medicare Advantage side and traditional Medicare, that restraint must come from the Congress ultimately. And our goal is to help Congress understand the implications of the pricing policies and give you the best advice that we can. So that's my opening statement, Mr. Chairman, and I'm happy to answer any questions about the report.
Thank you. I guess on the Medicare Advantage issue, I'm not sure that there's any question that we are overpaying relative to what the same procedures might cost us under the fee-for-service schedules. And it's a lot of money. I don't know, how many $1 billion a year are we overpaying? Do you, it's 10, 5, 10 billion a year? I don't know.
Per year, it's about $10 billion.
10 billion a year. I want to go back. Just we used to have something we called cost-based. How did we used to pay people like Kaiser? We had a term for it.
Yeah, well, if you go way back, there were cost contracts. In fact,
cost contracts. But basically, we were paying, let's take Kaiser, which is in my district, on a cost contract formula for this, just about, as far as I know, the same services they're providing today. But in those days, we paid generally less than 100% of fee-for-service. Now, what troubles me is how can I come to grips, or what reason could there be when in the past we were paying somebody like Kaiser, a managed care plan, less than 100%. They were doing fine. There was they never came to me and said they were about to go bankrupt or disappear. And all of a sudden, we're paying them, I don't know what, in Kaiser's case, maybe 108% today, for the same services they provided previously. What possible reason could there be for doing that?
Well, let me just quickly talk about the history. You know, the major change in how we paid private plans was, the first major change was in 1982 in TEFRA, at which time I worked in the Reagan administration, and we were very excited about the opportunity for private plans to enter Medicare and participate in what were then called risk contracts.
Risk contract,
right.
That's right.
And so Kaiser and other participating plans were paid a fixed monthly payment set at 95% of the expected Medicare costs for the same population. And what it's made us excited about it in the Reagan administration was that we thought the private plans could contribute something to Medicare, that properly configured plans could add value for the program and Medicare beneficiaries. And so the 95% formula said if you can do it for less, you're welcome to come into the program and help the beneficiaries. In a series of steps after that, of course, we left the 95% standard and adopt new payment formulas, which ultimately have led to us paying, on average, 113% more. The major concerns about that policy, paying 113%, are two. One, obviously, it increases outlays in the short run, strains the trust funds and all that. But from my perspective, perhaps an even bigger concern is that we're shaping the market. we're shaping the type of private plans that come into Medicare. The benchmarks that we use are a signal about what Medicare wants to buy. That's the function of prices in a marketplace. And basically what we're saying to the marketplace is that we welcome plans to come in and participate in Medicare that basically mimic Medicare. They offer fee-for-service coverage. They're not adding value. And that's the innovation that we want to buy. I think that's a luxury that the program can ill afford at this point. What we want is a payment system that encourages innovation, improvements in efficiency and quality. Plans like private fee-for-service, which are prospering under the existing payment system, are not adding value to Medicare. Their existence, their rapid growth, is a sign the payment system is flawed.
How do those private fee-for-service plans, if you will, for the committee, how do they differ from fee-for-service Medicare? What's the difference between a private fee-for-service plan and the old-fashioned standard Medicare fee-for-service?
Well, in terms of what they're required to do, there's really not much difference at all. By statute, they're required to pay providers on a fee-for-service basis. They're not supposed to limit the beneficiary's choice. They're not supposed to link payment to utilization, et cetera.
How about extra benefits?
Well, they provide extra benefits out of the additional payments that they get over and above the cost of traditional Medicare. So, in fact, let me just share a couple figures on this. So in this slide, I assume you can see it, the bottom row there is...
It doesn't show up, but that's our... Is it in your...
Yes, okay, so you have, this is the, oh, there we go.
There you are.
It's on the screen now. So I'm looking at the bottom row, which is private fee-for-service. So on average, the payments to private fee-for-service plans are 117% of what Medicare would have cost for the same beneficiaries. Their bids are 108%. And then the benchmarks are 120%, so they're focusing on areas where the benchmarks are high. And then the rebates are 9%. So what this is saying is we're paying them 117% of traditional Medicare. Only 9% of that is going back into added benefits for Medicare beneficiaries. The other 8 percentage points is going into the higher costs for the plans, whether they be higher utilization rates or higher administrative costs, whatever. So only about half of the overpayment is actually making it to Medicare beneficiaries.
And am I correct in assuming that none of us know what, if any, additional benefits are actually used by the beneficiaries? We know they are, quote, offered, but there are no records, as I understand it, as to whether they're actually being consumed or used, have any cost to these private fee-for-service.
Well, under the terms of the Medicare Advantage program, plans that are only required to submit limited data that supports the risk adjustment system. They don't have to provide a detailed encounter data on all services provided. And without that encounter data, it makes it difficult to assess the value.
If it was decided, whether we decided or it was recommended, that many of these extra benefits should be added as basic benefits in Medicare, is there a more efficient way to provide them?
Well, again, going back to the slide, that row on bids, what that 108% number means is that the plans themselves say it costs us 8% more than traditional Medicare to provide the basic Medicare Part A and B benefit package. So they're saying we cost more than traditional Medicare. So if the goal is to provide additional benefits to Medicare beneficiaries, a more efficient way to accomplish that goal would be to do it through traditional Medicare.
You are working, it's my understanding, MedPAC is working on the issue of how to revise the physician reimbursement plan.
Yeah.
And we'll hear from you about that later on.
Mr. Chairman, could I just add one other point?
Sure.
On Medicare Advantage?
Yeah.
I do want to point out that, I'm focusing on the bottom row there on private fee-for-service. If you look at the HMO row, there are some private plans that provide the services for less than Medicare's costs. And so the average HMO bid is 99% of Medicare costs.
99?
99%. And so in that case, and some HMOs do substantially better than that. So in that case, the private plans are more efficient at providing the additional benefits. So I just wanted to make sure that was clear.
Can you differentiate at all? I mean, between those that are bidding at par or less with those who are bidding more? Are we, I mean, is there any
What type of plan?
Yeah, or how they operate? I mean, is there any way you can distinguish statistically how they differ?
I'd point to a couple things. One is that there are geographic differences, as Mr. Camp alluded to. In some areas of the country, the traditional Medicare costs are very high. And private plans are able, many private plans are able to bid less than the traditional Medicare costs. In other parts of the country, the traditional Medicare costs are significantly lower, and it becomes more difficult for a private plan to bid less than the Medicare fee-for-service costs. So geographic differences are important. Also, plan type is important. More tightly organized systems like Kaiser Permanente, generally speaking, have lower costs than looser systems like private fee-for-service or large network HMOs.
Let me just get one more question in here, and I'm going to yield to Mr. Camp. He's been patient with my inquiries. In the area of comparative effectiveness, and it's my understanding that we are perhaps one of the few industrialized nations in the world that doesn't have some form of comparative effectiveness studies, certainly for pharmaceuticals, if not for medical procedures. We came fairly close on a bipartisan basis to, I think we came together on a bipartisan basis that it would be useful for us to have a comparative effectiveness program. My understanding is that we came apart on Blue Cross complaining that if they were going to pay anything, they wanted to control the system. I personally felt that it had to be at least a private-public partnership. And we had, in a way to pay for it, we had suggested that the government should pay some, and the insurance companies who would benefit from the use of this data should pay, I think it was $2 a year per insured, which hardly seemed, considering how much money they make, a burden for them. Can you give us an outline of what you would suggest as how we would set up a body to ensure independence, that the effectiveness research had a stable funding source and could maintain its independence? Have you got some, I mean, this is what I think MedPAC does, although we pay the full freight, the taxpayers do. How would you suggest we set that up?
Yeah. We'll actually address this issue in some more detail in our June 2008 report. So it's an issue that's currently under active discussion within the Commission. What we've said to this point is that we think it's critically important that the entity be perceived as independent. The whole idea here is to have an entity that exists to produce the best available information, not just for payers, but also for patients and physicians. And given the sensitivity of the topic, it'll only be credible and useful if it is seen by all parties as independent. Second, we believe it's very important that the organization have a secure, stable flow of funds and not be subject to having to ask various parties for money each year. That would limit its effectiveness, limit its ability to invest in major research. As to the specific mechanism for financing, we've not made a recommendation on that, but it does seem to us that it ought to come from the people who benefit from the research, which includes both the public and private payers. Now, there are various ways that might be accomplished.
Is your board close to unanimous in its agreement with those principles, or
Yes.
are you? They are.
We are.
Okay. Well, I'm happy to hear that, and look forward to what you in your report to us in June or any sooner that you could let us know what your deliberations decide.
And I might add that within the commission, it's some of the physician commissioners who have been most articulate about this. As practicing clinicians, they feel that the quality and the amount of information that they get about what works for their patients is less than they would desire, less than they need.
Thank you very much. Mr. Camp?
Thank you. Mr. Hackbarth, the Medicare Modernization Act in 2003 had a number of provisions to improve Medicare Advantage payments. Mm-hmm. Have these changes stimulated growth, particularly in the underserved rural areas? And so have they actually succeeded in providing rural seniors with more options?
Absolutely.
The MedPAC report found that Medicare Advantage plans were paid about 13% more than traditional fee-for-service. Did you take into account the value of extra services like dental and vision care, preventative services like annual physicals, free annual physicals that Medicare Advantage plans provide?
Well, what we're looking at in that number, the 113%, is the amount of the payment as opposed to the additional benefits provided.
That's just a raw score, so it does not take into account additional benefits.
In the slide that I have up, Mr. Camp, the additional benefits that the plans are providing over and above the basic Medicare benefit package would be reflected in the rebate column. Okay. So they're providing services estimated to be 9% above the traditional Medicare benefit package, but they're receiving payments equal to 117%.
Did you include the value of the assistance Medicare Advantage plans provide in helping beneficiaries with lower co-payments and deductibles as well?
That would be in the rebates, yes.
You also say in your statement that we're not receiving value for the additional money in Medicare Advantage. However, GAO found that beneficiaries in traditional Medicare pay $800 more per year than those in Medicare Advantage. And the Kaiser Family Foundation report found that while all beneficiaries save more money in Medicare Advantage, but on average, those with the highest health care costs save more than $4,000 a year by being in Medicare Advantage. Are you familiar with those findings?
Yeah, and I think I can explain how they fit into our analysis.
Would you describe those as receiving value?
Well,
those individuals?
The same additional benefits could be provided by Medicare, traditional Medicare that is, at a lower cost. The plans themselves say that their cost to provide the Medicare services are higher than traditional Medicare's.
But traditional Medicare doesn't provide those
apples.
services. So you're assuming that then traditional Medicare would then continue to provide all of those services.
Well, to the extent that what
Medicare
the
Advantage.
plans are doing in their additional services is filling in deductibles, co-insurance, paying premiums, I think that's a reasonable assumption.
But also dental and vision care and other items. You mentioned reducing those Medicare Advantage payments also to spur efficiency and innovation. Are you suggesting that the healthcare delivery systems in North Dakota and Wisconsin are 10 times more inefficient than those in New York and Florida? Miami particularly?
Well, the states that have low traditional Medicare costs would tend to be more efficient, not less efficient. In fact, in many of the low-cost Medicare states, as you know, not all of them, but many of them also tend to do quite well on quality measures. And so traditional Medicare is providing very good value in those low-cost states.
Well, so that is, yes, those with higher Medicare spending and utilization often have lower health and quality outcomes to areas compared to areas that are where utilization is much lower. I think that's what you're saying.
I'm sorry, say that
I think
again.
what you're saying is that benchmarks vary widely across the country, and that you have found that in regions with the highest Medicare spending and utilization rates often have health and quality outcomes similar or worse than
Yes.
those areas where utilization is much lower.
That's
Is that
correct.
a fair statement?
That's correct.
Are you exploring ways to ensure that seniors in states like Michigan will not continue to subsidize the overutilization of services by paying higher monthly premiums and deductibles in Florida and other areas?
Yeah, well, much of our work is aimed at trying to improve traditional Medicare so that it incorporates stronger incentives for efficiency and quality. So yes, that's what we spend most of our time trying to do.
All right, thank you. I see my time's expired, Mr. Chairman. Thank you.
Mr. Doggett, would you like to?
Thank you very much for your important continuing work. I would like to direct your attention first to the section of your report captioned Part D data still unavailable for purposes other than payment and the related recommendation. In that portion of your report, you say that in calendar year 2006, Medicare and Medicare beneficiaries under the prescription drug program paid out about $50 billion in premiums. But, quote, because of gaps in available data, there are fundamental questions that cannot be answered about how Part D is operating. I think this is a very troubling finding, and your recommendation to try to get CMS and HHS to do what they are charged under the law already, I believe, to do is very important. I've just been consistently amazed at this administration's tolerance of waste, fraud, and abuse in the Medicare Advantage program. I have apparently that it's okay to have waste, fraud, and abuse in government programs as long as it fulfills an ideological imperative and benefits insurance companies. Specifically, for over 8 months, I've been trying to determine whether all of $100 million was wasted or just a large part of it in this program to provide prescription drug assistance to people who weren't told in a timely way they were entitled to get it, and the refusal of CMS to go back and take a look at whether all that $100 million was wasted or just a large part of it. I asked in this room in June, I asked in October, I asked when Secretary Leavitt was sitting where you are when he came to testify about the President's budget. I asked again last week in the Budget Committee. CMS continues to refuse to explain what happened to that $100 million for low-income beneficiaries. Let me ask you, as a nonpartisan research organization with no political agenda, the Medicare Payment Advisory Commission, has the administration formally or informally been willing to provide you with the facts that you need concerning either this $100 million payment are the overall experiment with Part D, $50 billion, and if not, has that refusal to provide data impaired your work to ensure accountability?
Well, I'm not sure about the $100 million issue, Mr. Doggett, but in general, we've been concerned that we haven't been able to get claims-level data on Part D so that we can answer basic questions about how the program is functioning. For example, which drugs are the most frequently used and how many beneficiaries are entering into the coverage gap, those sorts of issues. Without that information, we fear we can't advise the Congress on how well the program, Part D that is working. So we have recommended that Congress pass legislation requiring CMS to provide claims-level data to MedPAC and other congressional support agencies, and also executive branch agencies that have health and safety responsibility, like FDA.
And you believe they could provide you that data right now, but given their attitude, you feel a mandate is necessary? Well,
my understanding is that there are at least people who believe that they don't have the legal authority to do that right now, which is why we've couched it as a recommendation that Congress enact legislation to make it perfectly clear that CMS is not just authorized, but required to give us the data. And obviously, it ought to be done so in a way that protects confidentiality to beneficiaries, and we have a very good track record of dealing with confidential information.
If you had that data already, certainly you have mechanisms within your committee to protect confidentiality.
Oh, yes.
You would have protected it had you been supplied the data you need to do your job. You have, even without that data, been able to do a great deal of research on the windfall subsidies that Medicare Advantage plans enjoy. They, of course, don't just go to low-income individuals. They go to people of all income ranges. Do you believe that Medicare Advantage is the best way to assist poor folks, low-income individuals with their health care cost?
No, we don't. We believe that there are other ways that are more targeted and would therefore be more effective at achieving the goal of providing support to low-income people.
I believe the latest estimate we have is that we will waste about $150 billion over the next 10 years on Medicare Advantage over delivering it through traditional Medicare. Just one last question, if I may, in another area, Mr. Chairman, and that is with regard to not so much these recommendations as the meeting that you had last week to begin exploring again this question of bundling hospital and physician payments for services around a hospitalization. Mm-hmm. As you know, when we had the so-called RAP DRG, there was concern about bundling radiology, anesthesiology, pathology services all together. Could you just give us a general idea of where you think MedPAC is going with this new bundled payment pilot, and perhaps tell us what type of select conditions might come into play, whether it's high volume or just generally what the conditions for which quality has been a persistent problem, but for which standard protocols are not available?
Yeah. Well, a couple points. First is we've not made a recommendation yet. We discussed a draft recommendation at our March meeting last week, and we will take up a recommendation in April. But I don't want to prejudge that the Commission will endorse that. The concept that we've talked about is starting with a select number of DRGs, focusing on particular conditions that are high volume and, for example, where there's a lot of variation around readmission rates and the like, focusing on those DRGs, and then for those conditions, bundled together in a single package, not just the hospital payment, but also the inpatient physician fees, subsequent hospital readmissions within a given window, like 30 days after the first admission. The ultimate goal would be to have a single fixed payment that goes to an organization that then divides it among the physicians and hospitals and others participating in the care. So that's the basic concept. To get to that true bundle payment, we're likely to recommend some transitional steps that would move us gradually in that direction.
Mr. Johnson, would you like to inquire?
Thank you, Mr. Chairman. You indicated that rural access has improved beneficiary choice to Medicare Advantage. And, you know, what would your proposed cuts do to Medicare Advantage to current beneficiaries' access? Is that going to impair them? And, you know, you need to know that the seniors in my district have asked me not to mess with their Medicare Advantage plans, and I note that Mr. Stark's percentage is way up there on numbers of people in your district who take Medicare Advantage. Compared to mine, you're about 5 times as many.
Yeah. Clearly, as I said in response to Mr. Camp, the additional payments that are being made to private plans are at least some of them going into added benefits for Medicare beneficiaries. And of course, we understand that that's very popular. But if the goal is to provide added benefits to Medicare beneficiaries, we believe that there are more efficient ways to do that than to funnel the money through.
Yeah, you made that statement before. You keep saying there are other ways. What are the other ways? Would you care to discuss?
If Congress wants to expand the Medicare benefit package, Congress can do that, and it would be at a lower cost than doing it through Medicare Advantage.
How can you be sure it'd be a lower cost?
The plans tell us so. Again, looking at the table before you, the plans say that it costs them more than traditional Medicare to provide the Medicare benefit package.
Well, but you also made the statement that it varies across the country. And you know, how do you equalize that?
Well, let's just go through some of the numbers here. On average, for all Medicare Advantage plans across the country, all types of plans, the average bid is 101% of traditional Medicare. For the private fee-for-service plans, which are, as you know, the most rapidly growing in the most prevalent form in the rural areas, the plans say that it costs them 108% of Medicare's cost to provide the traditional Medicare package. So there certainly is variation. But in the rural areas, the private plans say it would cost us quite a bit more than traditional Medicare to provide these benefits. That's what the plans say. That's what their bids say. So if we want to provide more benefits to Medicare beneficiaries, it's more efficient to do it through traditional Medicare than through private fee-for-service plans. I would also add that, you know, if the goal is to improve geographic equity, if people feel like traditional Medicare is unfair to, you know, parts of Texas or to Michigan relative to Florida, the place to fix that is in traditional Medicare, not in paying additional money to private plans in those areas. When traditional Medicare pays a lot more for, or when Medicare pays a lot more for private fee-for-service in Texas, or in Michigan, or in South Dakota, a lot of that money is going into higher administrative costs and profit for plans. It's not going to the health care providers in those states that have produced those low traditional Medicare costs. It's going to insurance companies. So if we want to improve geographic equity in traditional Medicare, fix traditional Medicare. If we want to provide more benefits to Medicare beneficiaries, Provide them through traditional Medicare. It's lower cost. It's more targeted.
So what you're saying is the government is a better insurer than private industry?
No, actually, I'm not saying that.
Yes, you did.
This is a critical issue, Mr. Johnson, so I want to be really clear on it. Is traditional Medicare lower cost, more efficient than private fee-for-service plans? Yes. The data say so. The data submitted by private fee-for-service plans say so. Is traditional Medicare more efficient than all private plans? No. Some of them bid less. HMOs, on average, bid less than the cost of traditional Medicare, and some HMOs significantly less than traditional Medicare. Some private plans are efficient, others are not. The problem with this payment system is we're rewarding inefficient private plans. In fact, we're encouraging growth in inefficient private plans.
Well, I think, would you agree that 75% of the people use HMOs?
75% of the enrollment,
Can you
yeah.
tell us? Is that true?
Yeah, but the most rapidly growing piece of this is the private fee-for-service.
Thank
The
you, Mr.
gentleman
Yeah,
from Texas
sure.
yield, just for a point of clarification. Mr. Hackbarth, are the coordinated care plans in a different position than the private fee-for-service? Are those still, I mean, your own data suggests they're providing services more efficiently, yet your testimony seems to lump everybody together. And if you could just clarify those points, I'd appreciate it.
Sure, Mr. Camp. Believe me, I'm doing my best to be clear on this. Not all private plans are the same. There is a lot of variation. We tend to, for analysis purposes, group plans into broad categories: private fee-for-service, coordinated care plans, regional PPOs, and the like. There are variations across those categories. Clearly, private fee-for-service is the least efficient option among the broad categories. Within a category like coordinated care plans that includes HMOs and local PPOs, as I recall, right? There are variations among HMOs in terms of their efficiency. Some of them are much lower cost than traditional Medicare. Some are higher cost than traditional Medicare. So the labels are imprecise.
Do you have a conclusion as a category, though?
On average, the HMO category provides the traditional Medicare benefits for less than traditional Medicare.
Thank you, sir.
Thank you,
I yield back.
Thank you.
Stubbs Jones, would you like to inquire?
Good morning, sir. How are you?
I'm doing well.
My name is Stephanie Tubbs Jones. I come from Cleveland, Ohio, and I'm concerned, and I've kind of looked through this report, and I'm not sure that it's included in that. You're familiar with all the research that shows that there are significant health disparities, particularly in the delivery of health care for minorities. Are you not, sir?
Yes.
Is there any place in this report where you address the issue of health disparities?
Well, there are places that we take care to look at differences. For example, in...
Can you refer me to somewhere in the report to that?
Yes. For example, in looking at dialysis facilities and closure rates, one of the things that we look at is the impact on different populations, including African Americans.
And what were your findings?
Well, in that case, we found that among the closing dialysis facilities, they were somewhat more likely to be facilities that have a disproportionate share of African Americans. It's not a huge disparity, but something that bears watching, we think.
And the reason you focus in on that is because end-stage renal disease predominates in African Americans and other minorities. Is that correct?
Yes, it's a particular problem.
Okay. And so what do you propose we do to address that particular issue, sir?
Well, in this case, as I said, we found a slight difference and think that it's something that bears watching. We don't think that there's evidence of an overwhelming problem at this point that requires
But
Correct.
if you're looking at a population in which it predominates, the slight difference could have a disproportionate impact on that group of folks.
All of the other statistics that we look at in terms of access to care for African Americans in general, the growth in services, et cetera, they all are in line with the needs of the population. So the number that I'm saying is a little bit something that bears watching is the closure of facilities. Are the ones that are closing disproportionately facilities that serve African Americans?
Now, so are
Slight
you
difference,
saying to
yes.
me that in terms of healthcare disparity, the only issue is the closing of end-stage renal disease facilities?
You know, we don't look at every issue with an eye towards disparities. No, we don't.
Is that something you could do?
We would be happy to look at particular issues, yes.
I mean, I think that in light of the fact that every research is showing that healthcare disparities dominate delivery of care to minorities is a big issue for minority communities, it would only make sense that you, who do the report to Congress on Medicare payment policy, would include that in your research. Could you see that that's something you include moving forward in the future?
Yes, we can take a look at that.
You are aware, in fact, I'm encouraging you to do so. And I'm going to stay on this healthcare subcommittee counting on you to provide that kind of leadership for us. You are aware that the committee, not the committee, the chair and I requested the GAO to do a study around end-stage renal disease and the impact bundling would have on end-stage renal disease. Is there anything in your research that speaks to that issue?
To bundling?
Yes, the bundling, the EPOGEN and the impact that it would have on minority communities.
Well, the commission has recommended bundling of ESRD-related services. And we've recommended that when that's done, that there be careful attention paid to incorporating measures of quality.
But when you made that recommendation, did you have any study upon which you based that it would have any disparate impact on minority communities?
No, we don't have information that would have
Could you please, again, I'm asking on behalf of the minority communities across this country in whom end-stage renal disease predominate, do some research in and around that. And when we receive this GAO study that we've requested, that you take a look at that to determine the impact, what impact your decision could have based on the study that they've done.
Yeah, and of course, we would be happy to do that. I would add, though, that we recommend bundling for ESRD services because we think that that system can produce better quality for all Medicare beneficiaries with end-stage renal disease.
But
the goal is to enhance quality as well as improve efficiency.
Exactly. But the question I have is, do you believe that doctors recommend drugs in order to make money versus standing in the stead of doing the job that they're supposed to do, which is to do no wrong?
Some doctors do that, and many do not.
So upon what do you base that answer that some doctors do that?
That some doctors
do that? That's what you just said.
I'm saying that there are doctors who will do things due to financial motivation and many who do not.
And upon what do you base that statement?
You can look at variation in utilization of services and look at things like how ownership affects utilization recommendations.
So do you have a research report that says doctors make that kind of recommendation? For profit versus looking out for the interests of their patient?
Again, I don't know if I'm misunderstanding your question. Are there physicians who recommend more because they're influenced by financial incentives? I say yes, there are some physicians.
And I'm asking you, if you have physicians that do that, do you have a report that shows that they do that?
There is abundant research that shows that there's a relationship between financial incentives and physician utilization decisions. There's research that shows there's a relationship between physician ownership of facilities in their decisions about utilization of those services. We don't produce every bit of research ourselves. We rely on work done by other researchers.
I'd be interested in having someone from the folks that are with you giving me the research that says that doctors would overprescribe a drug for purposes of profit versus looking out for the interests of their patient. And I'm out of time, so I'm looking for you to send that to me.
Well, again, the point is that physicians respond to incentives.
I don't know if anybody in the physician community is sitting out there listening to these blanket statements that you're making, but I'm confident by the end of the day you're going to hear from a whole bunch of them.
Well, we've got physicians on MedPAC who would agree with that statement.
Send it to me. If you have it, I'd love to read it. But I'm telling you, by the end of the day, I'm confident you're going to hear from a lot of physicians who do not agree with that blanket statement you're making about their practice of medicine.
And in fact, just so the record's clear, I did not make a blanket statement. What I've said is that some physicians do, most do not.
I'll let the physicians argue with you. Thank you, Mr. Chairman.
You're welcome. Mr. Kind.
Thank you, Mr. Chairman. Thank you, Mr. Hackbarth. I appreciate your testimony today and also MedPAC's work and the report that you submit. Obviously, you give us a lot of policy issues to chew on in the course of the report. Skilled nursing facilities, home health. I'm very concerned about their status back in Wisconsin. Obviously, MedPAC's recommending is 0%. Right. And that's based on what the Medicare margins are right now, is my understanding. The problem we're facing, however, is the state funding issue, which many of us have believed has been inadequate, especially in Wisconsin, for too long. And yet they keep coming to us, seeing if there's any type of help or relief in light of the funding shortfall that's occurring at the state level. Mm-hmm. You probably weren't paying attention, but a couple of weeks ago we just passed reauthorization of the Higher Education Act, which had a maintenance of funding language in it, basically telling the states, listen, if you're going to make a policy proposal to reduce funding for higher education, don't expect the federal government then to come up and make up for the shortfalls in that. I'm just wondering whether or not something like that might be necessary in order to address the skilled nursing facilities and home health issues, since Medicare's margins are above and beyond, and yet the state funding seems to suffer each year as we go forward, and then jeopardizing that care back home.
Yeah.
Did MedPAC look at anything like that? Or?
Well, what we have said is that using Medicare funds to offset Medicaid shortfalls is a mistake for two reasons. One, if the federal government says we'll assume responsibility for the bottom line of nursing homes and home health agencies, that's the reason for the state and other payers to say, oh, we'll reduce the amount we pay because the feds will make up the difference, and that's the issue you're getting at. The second aspect of it is that if we use Medicare rates to cross-subsidize for low Medicaid payment, the skilled nursing facilities, for example, that are going to get the most money are the ones that have the highest Medicare caseloads and the lowest Medicaid caseloads. And so the money's not going to go to the right people. Okay. So if you want to fix low Medicaid rates, you got to fix Medicaid, not do it through Medicare. As to how to fix Medicaid, that's beyond the scope of the Medicare Payment Advisory Commission, so we've not made a specific Medicaid recommendation.
Let me just relay the sense of frustration again that many of the providers feel back in my district in western Wisconsin. High quality care, one of the lowest reimbursement regions in the entire country. Mm-hmm. Now, if we were to move forward aggressively, getting e-prescribing, HIT in place with quality of care standards and move to an outcome or performance-based reimbursement system, how much cost savings do you think that would bring the Medicare system in light of the solvency issues that have been highlighted here today?
From HIT in particular?
Yeah, from HIT, but also going to a performance-based type of reimbursement system that also deals with the utilization variances from regions.
I don't know, Mr. Kind, exactly what the number would be. You know, people have looked at some pieces of that. The RAND Corporation, for example, tried to look at the potential long-term savings from HIT. MedPAC specifically has not looked at those issues. But potentially the savings are quite large from improved efficiency.
And you're probably familiar with the type of provider initiative that's taking place in Wisconsin, where they are trying to, this new quality collaborative initiative that all the providers have bought into in the state, and trying to establish standards, increasing transparency, and getting that data available, which I think makes a lot of sense, as long as you can get that type of integration and cooperation across the providers. But naturally, we do have a solvency issue, but one of the issues coming up this year was going to be the 45% trigger issue. Is MedPAC have any thoughts about that 45% trigger?
Well, we've not made any recommendation on the 45% trigger per se. I would say that, as I said in my opening statement, the Commission's very concerned about the solvency of the program. And feels a growing sense of urgency about that. So to the extent that the 45% trigger reflects the same sense of urgency, that's good news. The problem with the trigger is that, as you know, it focuses on the portion of the program that's financed through general revenues. And so it's just looking at a piece of the financial picture, not the overall cost of the Medicare program. And so in that sense, the 45% trigger is inadequate to deal with our big picture issue, which is the total cost of the program, whether it's financed from general revenues or
right.
the HIT.
What are your thoughts on these so-called efficiency payments, trying to incentivize increased efficiencies and cost savings in the delivery of health care? Are they going to be effective? Are they going to?
We've got to move in that direction. You know, we need to move in that direction with care. We need to make sure that the system includes quality measures to assure that we aren't hurting quality as we try to lower costs. We need to take care that there's appropriate adjustment for patient case mix and severity of illness, so there aren't incentives to avoid the sickest patients. But the direction is the direction we need to move. We just need to move there with care and thought.
Great. Thank you. Thank you, Mr. Chairman.
Mr. Pomeroy, would you like to inquire?
I do have a few questions. I'd first like to pick up on my colleague's comments about the skilled nursing home care reimbursement issue. Now, MedPAC is an advisory committee for Medicare, so maybe MedPAC only needs to look at the Medicare component of reimbursement under CMS. But I believe the responsibilities on us as members of the Ways and Means Committee needs to be a little broader, even though Medicaid jurisdiction falls principally on the Commerce Committee. But what we have for the nursing home in North Dakota providing services, much of which is paid for by federal programs, Medicare or Medicaid, is negative margins. They're getting negative margins because they're losing their shirt on Medicaid reimbursements being below costs. And they've been able to cross-subsidize a little bit with the margin, favorable skilled nursing care margin on Medicare reimbursements. So simply without attending in any way to the underpayment on Medicaid, hammer now the margins on Medicare, at the end of the day, for the institution we demand provide quality care to the senior in that home, we're only making the job much more difficult. And I believe that you could even look at it a little more expansively as a Medicare problem as well. If the institutions are in aggregate in negative margins because of a federal program, it seems to me we better be somewhat tempered in what we do on the Medicare side, lest we drive the quality or the availability of care in the nursing home area to where we can't get acceptable outcome for the Medicare reimbursements that we make. I'm going to have that as a higher priority personally in the year ahead as we look at this. But I want to ask you about a few different things. Growth we're seeing in the Medicare Advantage is all in the private fee-for-service side in North Dakota. An awful lot of aggressive marketing has produced some substantial enrollment change recently. Man, I just don't see much quantification of the private fee-for-service return for the 17% we pay over the cost of Medicare, paying for the benefit on a fee-for-service basis. Is that substantially MedPAC's view as well?
Mr. Pomeroy, again, I'd refer you to the table that's on the screen. So that last column, the rebates, that's the amount of money that goes back to Medicare beneficiaries in the form of added benefits, reduced premiums. So of the 117% payment, overpayment, 9 percentage points of that 17 is going to the beneficiaries in the form of added benefits. The remaining 8% out of the 17 is going into higher plan costs for administration, profit, et cetera. So some of it is making it to beneficiaries, but only about half.
Yeah, for whatever enhanced benefit we want, we're paying $2 to get a buck's worth of good out there.
Right, exactly.
Ought to be a more efficient way of doing that one. There's a book I would commend to you, if you haven't read it, Overtreated, Why Too Much Medicine is Making Us Sicker and Poorer, written by Shannon Brownlee. New York Times called it the #1 economic book in 2007. And it talks about vast differential in practice patterns, not reflected to improved outcomes, in fact, potentially inversely related to preferred outcomes, adding costs that the author estimates to be $500 to $700 billion a year. Now, as a system, is Medicare incapable of responding to a practice pattern in one place that's carving people up at a rate that's totally unmatched in other parts of the country without any better outcomes to show for the cost and the trauma to patients?
Well, one of the tools that Medicare has at its disposal is, in fact, to use private plans. Traditional Medicare has some strengths. It's large. It can get good rates from providers because of its size. It has low administrative costs because of its size. Traditional Medicare's weakness, historically, has been its inability to change practice patterns and deal with this sort of issue. And so part of the original thinking around Medicare Advantage was, well, if we allow private plans to come in and they can selectively contract, they can better coordinate care and the like, they can deal with some of these inappropriate utilization patterns maybe more flexibly than traditional Medicare. I still believe that that's true. The problem with Medicare Advantage is the payment system that we're using rewards inefficiency as well as efficiency.
All right. Thank you, Mr. Chairman.
Thank you. Mr. Thompson, would you like to inquire?
Thank you, Mr. Chairman. I would. Thank you, sir, for being here today and helping us work through this these vaccine issues. In the administration's budget, they were silent on the issue of addressing the impending physician rate cuts, which I take to be a silent endorsement of the cuts. And it's interesting because CMS's own actuaries seem to recognize that cuts of this magnitude will impact access to care. As a matter of fact, they said that it would substantially reduce beneficiary access to physician care. Does MedPAC agree that cuts in the range of 10% would have an impact on beneficiaries' access to care? And do you have any comments as to how you think Congress should deal with it?
Yeah, it is quite possible that a cut as large as 10% would start to affect access to care, in particular in some markets. MedPAC's recommendation is for an increase in physician fees equal to the increase in their input prices minus a productivity factor. It works out to about 1.1%.
And that would avert any reduction in care
Yes,
to
we think a modest increase in payments is appropriate.
I'd like to follow up on something our colleague, Ms. Tubbs-Jones, mentioned, and that's the issue of bundling of Medicare payment rates for dialysis. And she said one thing that, she asked you one question that I was somewhat perplexed by your comments, and that's the fact that the closing of these facilities. And I didn't hear any mention on your part that that there's a nexus between reimbursement rates and the ability of some of these facilities to stay open. And I think that was that's something that maybe it's intuitive, but it is important to note that it's more than just the reasons that you stated for folks to stay open and continuing to be able to provide care. If they're not getting the reimbursements they need to keep the doors open, they're going to close.
Yeah, could I comment on that, Mr. Thompson?
Sure.
Just to be clear, the number of facilities closing in any year is quite small, and maybe somebody can get that number.
Well,
I didn't mean to overstate the closure problem, but I was giving it as an illustration of where we have looked in particular at a disproportionate impact on certain communities like the African American community.
The actual number is less important to me than the fact that people who need this care, I mean, it's very, very important, have the ability to do it. And maybe, I don't know where you live, if you live in the city here, or maybe it's easy to get to them, but I represent a district that's largely rural. And it's tough for people to drive, especially to undergo this type of treatment, to drive any great lengths. And I'll stipulate that bundling probably does save money, but I think it's important also to point out that it's more than just saving the money. There's a quality to health care, quality of health care and access to that quality of health care issue that I think has to be put in place. And I'm hearing rumors that, given the support for the bundling, that there may in fact be something along this line. But I think we need to do some better tests than the tests that have been proposed so far. And I think that those pilots or tests or whatever you're going to, the matrix that you're going to set up to determine the impact that this is going to have on very real people with very serious health problems, that it take into consideration not just the savings associated with this, but also the impact it has on someone's access to quality health care. And I'd like to see something come out of MedPAC that would address that issue.
We agree that designing the system so that it doesn't just preserve quality, but I think can even enhance quality. That should be the objective.
We just need to make sure we do the work on the ground, so we're not modeling after urban facilities, and we need to take into consideration the impact this is going to have on rurals. And then one last question. The administration held Medicare Advantage Plus harmless, and this has been talked about a little bit already, but in the budget that cut the rates for almost every other provider group. And it seems to me that if in your work, you're suggesting that the Medicare Advantage plans take up about $10 billion more for beneficiaries enrolled in those plans. And without, my question to you is, without reform, do you see the MA reimbursement rates continuing to tread upward in comparison for fee-for-service? And what can you suggest that beneficiaries are getting that make this this extra expenditure worthwhile?
Well, so long as we keep the current payment system, we expect that enrollment will continue to grow. And each new beneficiary is costing traditional Medicare more, so the cost of the program will grow with that additional enrollment. That's one of the reasons we think it's important to act on this as soon as possible.
So $10 billion today?
It'll be bigger in the future, so long as you leave these payment incentives in place.
Yeah.
We're at risk in the extreme of taking large portions of the country where traditional Medicare's costs are relatively low and quality relatively high, and moving all those beneficiaries into higher cost fee-for-service plans that add no value over traditional Medicare. And the price tag for that will be very, very large.
And as far as what these beneficiaries are getting for this $10 billion extra?
Well, again, the table that we've discussed summarizes the data. In the case of private fee-for-service, which is basically doubled in size, it's the most rapidly growing, doubled in size over the last year. It's the most rapidly growing piece of Medicare Advantage. Only about half of the overpayments are going into additional benefits for Medicare beneficiaries.
Thank you very much.
Mr. Becerra, would you like to inquire?
Yes, Mr. Chairman. Mr. Hackbarth, thank you for being with us again. And once again, thank you for the report, your testimony, and the good work that the Commission has been doing. I'd like to focus my first question on some of your recommendations pertaining to trying to increase the participation rates by modest income Medicare beneficiaries in the Medicare Savings Program and in the low-income drug subsidy program as well. You make some specific recommendations, which I think you've made in the past. I know I've heard you say this. One is that the Secretary of Health and Human Services should increase the funding for outreach to low-income Medicare beneficiaries to participate in the State Health Insurance Assistance Program. Two, you call on Congress to raise the Medicare Savings Program income and asset test to conform to the low-income drug subsidy criteria that we have, so that you bring them together and let low-income folks who happen to have some modest assets still qualify without having to become so poor before they're able to get some assistance to get their Medicare benefits. And you also talk about Congress changing the program requirements so that the Social Security Administration would be able to screen low-income drug subsidy applicants for the federal Medicare Savings Program to see if they're eligible, and if they are, to be able to enroll them, in essence, a one-stop shop, so that if the state's finding out that these folks qualify, or the SSA is finding out that they qualify for one thing, chances are they'll qualify for the other, and rather than have them not know the other, we get them into the boat getting their health care right away. You've made these recommendations before. Our bill, the CHAMP bill last year, tried to implement them. We've not gotten there. Why do you keep making these recommendations? Is there beyond the social desire of trying to get folks who qualify, who are eligible for these benefits, to know about them, is there a financial savings as well?
Well, I'm not sure that there would be a financial savings, at least not in the first instance. These increase outlays.
To the overall system.
It's money well spent.
Right. To the overall system, I guess.
No, frankly, the context in which we took on these issues was influenced by the Medicare Advantage debate. A lot of people said, well, Medicare Advantage is providing support for low-income beneficiaries. It's making it so that they can get added benefits. And that's a worthy, important goal. And so we said, well, there are other ways to achieve that goal more efficiently without just sort of spreading money all over the country. Let's target it to low-income people. We have vehicles in place, namely the Medicare savings programs. Let's change the rules there so that they're more effective.
So we could be more efficient if we're able to target it through these programs that already exist.
Yes.
Okay.
That's our thought.
Let me ask another question. I know there's a constant debate about the issue of the high-deductible health plans and the health savings account that the President has really promoted for quite some time, really provide resources for those who are in these high-deductible health plans. These plans, my understanding, is run the risk of being attractive to individuals who, for the most part, are healthy or wealthy. But when you take into account that 80% of our health care costs are for 20% of the population, it seems to me that the 20% that is at most risk of needing health care, they're the folks that are least likely to go into these health savings accounts and these high-risk deductible plans, because their upfront costs would be too tremendous for them to be able to afford that type of an insurance program. Any comments?
Well, we've not looked specifically at the issue of the high deductible plans. We do refer to some research in our report that's been done by other people that suggests that, yeah, maybe there is a selection effect here, that they're most attractive to people who have relatively high incomes and who are relatively healthy. I would note, though, that it's pretty early in the development of the idea, and so it's probably premature to draw definitive conclusions. You know, from my own personal perspective, I guess the big question I have about the effectiveness of the high deductible plans, having been in one myself, actually, is are they going to help us deal with the health cost problem, which, as you say, is that 20% of the population that uses 80% of the resources. People who have multiple chronic illnesses are going to blow through these deductibles. And once they're through the deductible, they basically have, you know, first dollar comprehensive coverage. So what's the incentive to reduce costs for, in the case of the people who use all the money? You know, are they going to solve our health cost problem? It's hard for me to see how they'll do that.
Well, I thank you for the report, because it seems to me you're trying to target these efficiencies that we can inject into the system, and I appreciate that, because one of the things we're finding is that we may have disagreements about how to do health care, but I think if we know we can save money and still provide health care, most of us in this Congress would be supportive of that. So we appreciate the reports and the recommendations that we've gotten from MedPAC. Thank you for your time.
Thank you.
Thank you. I had a couple of questions, Glenn. You continue to recommend a bundled payment for dialysis providers. Do we need to do a demonstration first before moving to a bundled payment system, or do we have enough information to proceed?
I think there's probably enough information to proceed, as is Mr. Stark. I don't think another demo is needed. Having said that, of course, it's very important to take care in the design of a bundle payment to include appropriate case mix adjustment and quality measures.
So that would take into account adjustments for minority populations or for rural settings, all of those issues that my colleagues have raised today would be taken into account in setting up a bundled payment system, and you have enough information, you feel, to do that?
Well, I think it can be designed to address the legitimate concerns that have been raised.
Okay. In the area of the for-profit skilled nursing facilities, you project Medicare margins of 11% in 2008 in the for-profit groups. Is there a variation in margins between the for-profit and not-for-profit skilled nursing facilities?
Yes, the average Medicare margin for the freestanding facilities, I think, is projected to be 11%, and the margin for the for-profits. Well, this is actually the 2006 data. So the overall average is 13%, and the for-profit was 16%, and the not-for-profit was 3%.
Why is that, and what should we do to perhaps bring them closer together?
Yeah, well, we have been concerned for several years now about the system used to pay skilled nursing facilities, and didn't feel like it was appropriately recognizing differences in some types of patients. And there are two particular components that have been troubling to us. How the system pays for non-therapy ancillary expenses, as are known, which is like drugs and respiratory therapy, things like that. And then how it pays for physical therapy, occupational therapy, and the like. In the one case, the non-therapy ancillaries, we think the existing system underpays. So these are often complicated patients that we think are not getting enough money from Medicare. On the other hand, the existing system provides very strong incentives to do lots of therapy, and there may be too much profit in that end of the business. We are looking at a recommendation. We talked about a draft recommendation last week that would change the payment system for non-therapy ancillaries and therapy and would have the effect of changing these margins. Margins at the for-profit skilled nursing facilities would fall. Profits at the not-for-profit agency or skilled nursing facilities would increase. I would also add that the financial performance of hospital-based skilled nursing facilities would also improve under our recommendation.
And you won't get me crosswise with Mr. Pomeroy in saying that we won't be disadvantaging rural providers or inner-city providers. That's all.
No, I won't. We think it's a fairer payment system that more accurately reflects the needs of the patients being served.
Mr. Camp, did you?
Yes, I just had a follow-up to the question you had. Obviously, MedPAC has recommended in past reports a bundled payment for dialysis services combined with quality monitoring, so this is not a new recommendation. Right. But what is new is that CMS has just completed their final report on a potential model for an ESRD bundled payment. In that, I understand there are a number of case mix adjusters. Are any of those including race?
I don't know. I think the CMS report came out like a week ago.
Yeah, I believe none of them. There are 22 case mix adjusters, and none of them are including race. Do you believe the model that CMS has developed can be used to implement a bundled payment system nationwide that accounts for both individual patient characteristics as well as the smaller dialysis facilities?
Because the report is a recent one, we're still in the process of looking at it. But as you point out, we have said for a number of years now, we think a bundle payment is the way to go.
And rather than a pilot program, do you believe a transition might be more appropriate to phase in a bundled payment similar to the transitions to reform payments to inpatient hospitals, skilled nursing facilities, long-term care hospitals, inpatient rehab facilities?
Yeah, in fact, that's a quite common thing in the Medicare program, where you're making a significant change in a payment system to allow a gradual transition. Yes.
And would it also not be suitable to provide a regular update that is built into the baseline, much like other providers?
I'm sorry, are you saying a statutory update?
Yes, to provide a regular statutory update that's built into the baseline, which is similar to what other providers receive?
Well, as you know, MedPAC's stock and trade is to look at a variety of different factors to make an update recommendation. Things like margins, access to capital, access to care for beneficiaries, et cetera. And those variables change over time. They change year to year in some cases. And so our basic approach on all updates is that you ought to do an analysis each year to determine an appropriate update. As opposed to writing a baseline that says, oh, they're going to get X percent every year into the future. So, you know, if anything, we'd like to see everybody on the same footing as dialysis facilities, which is no automatic increases.
So you're suggesting we remove the built-in baseline update for other providers?
We think that determining the appropriate rate increase is something that ought to be done year by year.
And how does that, if that's completely open year to year, doesn't that make long-term planning somewhat difficult, particularly in hospital settings and other large concerns that have a variety of business decisions to make, as well as the care of patients?
Well, most businesses don't have guaranteed updates. They have prices set by competitive markets, and, they still manage to plan. They make assumptions about what it's going to be. They respond to changes in prices by improving efficiency. The norm. In the
There's
business
also
world,
more
there's no
choice
guarantee.
available in the private sector in many cases than there is in the health sector. We don't always have the comparable choices available, but I understand the point you're trying to make. I do think it is a little different when there's a sole provider community hospital to say that they're just like the 3 auto parts stores that are in town. I think there's a bit of a difference there.
Yeah, in cases where there is a sole provider and it's a critical access institution, there aren't readily available alternatives, we ought to target those institutions in particular, as you folks have, set up special payment systems for those isolated providers. But where there are alternatives, I think that living without price guarantees is the way the economy
Well, I
works
think in many
general.
large cities you have lots of alternatives, but in most of America there aren't lots of alternatives. So yes, if you live in a large urban setting like Washington, D.C., you've got lots of choices. But even in parts of the city, you have to travel a ways to get to those choices. So anyway, I appreciate the chairman's time. Thank you.
Just one more issue on this dialysis thing. According to your report, we're spending about $26,000 a year for each patient, right? I think that's in your report somewhere.
Okay. I don't have that number in my head.
And the for-profit, there are 2 big for-profit chains, and their average margin is 7.6%. Everybody else is around 2% margin. Is there that big a disparity in quality between the those that aren't in the 2 big chains?
Yeah, well, as you know, the payment system isn't at all based on quality.
No, I just wondered if you know. Is there?
Yeah, not that I know of. I don't know that there's a quality advantage in the big chains.
So we're paying these guys 3.5 times as much, and you don't think there's 3.5 times better quality. I was just looking the other day, and in most every other country in the world, dialysis is done through hospitals. What if, and assuming that we'd have to keep the patients happy by having little clinics all over Hell's Half Acre, but the hospitals could run those just as they often run outpatient. What if we just, we're talking about this huge margin, and the hospitals none of them have margins getting near 7% on average, where most of our hospitals. What if we just gave this extra money to the hospitals and said, you guys run it? Some hospitals do it as a part of their service. What would be wrong with just turning the whole dialysis program over to our not-for-profit acute care hospital system and give them the margin?
Well, in general, we favor having choices for beneficiaries and competition in the belief that that can make things.
They have a choice. In many areas, they have a choice of hospitals. In some areas where...
Right. But to designate a particular provider type as the only one who can provide a service, particularly what is basically an outpatient service like this one, wouldn't be the approach that MedPAC would normally take. What we try to do is devise payment systems that are neutral to provider type.
This is the only service that we pay for everybody. In other words, if America, this is socialized medicine. Dialysis is the only procedure that we pay for everybody, and the government pays the whole freight, and so that it arguably is a different procedure. And if we're going to set the price, maybe we could set the the setting. And we're also worried about the financial health of the hospitals. And I just suggest that maybe this would be a way to give them a little extra revenue. They certainly have the extra, and in many cases they do it in hospital settings. It sounds to me like it's some low-hanging fruit that might help our hospital system provide competition, provide access, all those things that. Be curious to see what you think. See if you can sell that to your board.
Yeah. I think it might be a tough sell.
If I might just follow up on one question. There is a different patient mix in the small rural providers and the large dialysis chains, is there not? They're not comparable patient populations, is my understanding.
Well,
So the margins would
honestly don't know
reflect the different population mix and payment mix of those two groups, would they not?
Yeah, I don't know that there is a difference, Mr. Camp. Maybe one of my colleagues.
Yeah, I think before we draw offhand conclusions on the margin differences between the larger chains and the smaller chains, I think we need to understand, is there a different patient mix in those two types of facilities? And I believe you'll find there is.
But do we have any information that the patients are different now?
It's just not very large.
Okay. We can provide you a more detailed answer in
Yeah, I would
writing,
appreciate
but there might be some differences, small differences in the patients served among the different types at this point. Second point I'd make
One may
is,
have a larger percentage of Medicare payment, other may have other payment. Could be quite a difference, sir. Anyway,
ideally,
I
what you want
appreciate the information.
in a bundled payment system, you want a case mix adjustment that deals with difference in patient need.
Glenn, thank you. Thank your staff, Mark, and the rest, all of you, for helping us through these thorny problems. We'll look forward to June report.
June report, yeah.
Get it in June or July? June.
Get it in June, yeah,
Great.
about the 15th of June.
Look forward to it. Thank you very much.
Thank you.